Hi, my name is Jake. Today I will be demonstrating an epidural placement, a spinal placement, and a machine check. The patient that I will be doing the epidural on is a 60-year-old female. She's here for a total knee arthroplasty. Arthroplasty, still can't say it. Her height is 167 centimeters, weight is 75 kilograms with a BMI of 26.9. She has a history of hypertension, hyperlipidemia, and aortic stenosis that's mild, and type 2 diabetes. Per the surgeon preference, he wants us to place the epidural, so that's why we'll be doing that with her. And then because of her history and other comorbidities, puts her as an ASA 3 for this surgery. Before I go see the patient, I'm going to go and perform my anesthesia machine check, make sure that the OR is all ready before I go check on the patient and do my assessment on her. So I'm going to go into the OR, I have my machine here. Before it's turned on, I'm going to check my pipeline supply, make sure it's connected and good, my power is connected, make sure that my reserve tank on the back is connected and popped open so I can check the volume that's there. The pressures for pipeline should be about 50. For the tank, it should be about 1,000. So those are all good. I'm going to make sure I have a BVM for an emergency, make sure it works. I'm going to make sure that I have suction and that everything's connected and on and working. I'll make sure my monitor is good and I'll turn it on. Make sure I have my EKG, blood pressure, SpO2 cords, and they're all good and working. Now I'm ready to do my low flow leak test. First, I'm going to make sure that my volatile agents are stocked and sealed tightly. Then I can move on and do my low flow leak test with the bulb, make sure it's good, make sure there's no leaks in the low flow meters or in the vaporizers, which there's not. Once that's done, I can turn my machine on. Once it's on, I can calibrate the machine to oxygen at 100%. That passes and is good. I'm going to check my CO2 absorbent, make sure it's not desiccated. And then I am going to perform a high pressure leak test. To do that, I'm going to include the white piece, close my APL valve, and I'm going to increase the pressure until 30 psi. Make sure I can hold for 10 seconds and then slowly open the APL valve, and I should see that it goes down with it, and that checks my scavenging system while I do that. So we're good there. And make sure all my alarms are set and good and my volumes and vent settings are appropriate for the patient. Make sure I can do both the ventilator mode and manual mask ventilation if I need. And so everything's good there, and that concludes the machine check. I'm going to go ahead and get my medications for induction, which we're not going to go over today, so I'll just make sure they're all ready. Because this isn't a labor epidural, I will get 2 milligrams of Versed ready for the patient just to help them with nerves as we're doing the epidural and the OR and such. And as we're going to do all this in the OR, I'm going to make sure that I just have all my epidural supplies. So I'll have an epidural kit or cart depending on the facility. I'm going to make sure that I have all my medications. If they're not already in the kit, they're ready. In this instance, I'll need some fentanyl. Just 1 vial of fentanyl will be enough to make up my mixture. The local should be in the kit, which it is. And then once that's all ready, I'm going to go ahead and go see my patient. I'm going to go verify the patient, check their name and date of birth, make sure it's the right person, make sure they're here for the TKA, which they are, and then I'm going to go ahead and just make sure I have their medical history complete, which it is, check their MPO status, and then I'm going to go ahead, check their labs. Their labs are good. In this instance, I want to check a potassium because everyone gets their potassium checked. But specifically with the neuraxial anesthesia, I wanted to check their H&H, platelets, and coags. Their coags are fine. Their hemoglobin's 12 with a hematocrit of 36 and platelets of over 200,000. So we're golden that way. I can move with my assessment. I'm going to do the heart and lung, make sure everything sounds good. I'm going to make sure that the airway is patent, check it, see how much they can open their mouth, their incisor gap, check the thyromental distance, that's fine. Mallampati of a 2, so that's good too. They have a class 1 upper lip bite test, so they can bite past up to the top of their lip. That's good. And then I'm going to check their their neck range of motion. That's all good as well. Now for this specifically, part of my assessment, I'm going to go and check their back, make sure that they don't have any hardware or anything in the way, make sure that they can kind of bend the way I need. I can feel the vertebral processes and the iliac crest, which I can, so that's good. So now that my assessment's done, I'm going to go over the procedure with them, just talk about how with this surgery we're going to do an epidural. The benefit to that is that they're going to have a more complete pain coverage in the OR and shortly after. And that will require less anesthetic, less opioids, so that will mean a faster recovery post-operatively with less potential post-op nausea and vomiting and constipation and such. The alternatives to this could be a spinal. However, in this patient, that isn't really a realistic alternative because of their aortic stenosis. We don't want to drop their blood pressure. Also, we could do regional with a saphenous nerve block or a popliteal block of the sciatic nerve. However, because of the surgeon preference, he wants the epidural, and the patient states that they want to do what the surgeon wants to do. So we're going to go with an epidural. I get consent from them for that. And actually part of the consent as well, I would talk to them about the risks of this epidural, which primarily is blood pressure, low blood pressure, which could cause some nausea up front, but I'll talk to them about the treatment for that through some fluids and blood pressure medications as needed. And then the biggest one is post-dural puncture headache. So if I were to accidentally puncture the dura, that would leak CSF, causing a severe headache, which would lead to requirement of a blood patch as a worst case scenario. So once I've gone over those risks, now I've obtained full informed consent from the patient. They agree with it. I take them to the OR, give them their Versed, make sure they're good and happy. I'm going to go ahead, pull them to the edge of the bed so that their butt is hanging off the edge here. So I have the best view. I'm going to make sure that they're in line. I'll have an assistant here to help pull them forward and keep them positioned as needed. I'm going to go ahead, palpate the top of the iliac crest, go across, which is called my twofer line. That puts me at about L3 or 4 on the patient. So I'm going to go ahead and just kind of feel for the spinous processes. I can feel them, find the one I want. So I'm going to go ahead and mark it. So that's marked and ready for me. Now I can go ahead and grab my kit. I'm going to open up my kit, making sure not to contaminate anything. So we're good there. Come over here, get my sterile gloves on. We're going to go ahead and get the skin prepped. Good, we'll throw that away. Done with that. And then as that's drying, I can go ahead and pull up my medications, which I've already discussed a little bit. For this patient though, for dosings, my test dose is going to be 3 mLs of 45 milligrams, 1% lidocaine, and 15 micrograms of 1 in 200,000 concentration epi. So I'll have that pulled up. Good. Get that pulled up. We have our loading dose, which is 8 mLs of 0.25% bupivacaine with 100 mics of fentanyl. That gives us 10 mLs total, and that's 25 milligrams of bupivacaine for that. And then I'm going to have my local up for just the skin, and that's 3 mLs of 1% lidocaine, which I will just administer as I go in before I put the tube needle in. Make sure I have all my supplies, make sure everything's labeled and good. And I'm going to go ahead, get 6 cc's of sterile saline in my glass syringe. Okay, so we're good there. All right, so now I have this all ready, it's dry. I'm going to go ahead and get my drape, making sure I don't have anything touch. I'll take the tape off, then I'm going to wrap it around me to make sure my hands don't get contaminated. I'm going to aim for the spot I measured, which which is right there. And for demonstration purposes, I'm just going to use this tape here to keep it in place. Okay, so we have the area we want that's taped up. I'm going to have my assistant help flex the patient forward a little more so I can get bigger opening of the spinous processes. You want to go ahead, palpate, make sure it's in the right spot. Get my local, just giving a skin wheel, make sure we're good. Once the wheel is complete, I'll kind of go a little deeper and just slowly progress, making sure not to go too deep though, because I don't want to go through the ligaments. So we're good there. I'm going to go ahead, I like that trajectory, so I'm going to leave the needle in since the patient's not going to move. Give it some time. Grab my 2E needle. And go ahead, get this started, get that out. And the sharps. I'm going to go ahead and advance the needle. And as I advance, I'm going to make sure that I use a Bramage grip, which will help secure the needle. And in the instance that the patient moves, the needle's not going to move any which way because I have it following and holding onto the patient closely. So I'm going to go ahead and advance this 2 centimeters. This is a slightly bigger lady, so that'll be fine. And then I'll remove that guide needle and get my glass syringe. And I'm just going to slowly, with the Bramage, insert a little bit, check, make sure I don't have loss of resistance, which is what we're going to use for confirmation. Although I should feel it go through the supraspinous ligament, interspinous ligament, and then the ligamentum flavum. So there we have loss of resistance. We're at about 5 centimeters. I'm going to go ahead and grab my catheter. So now for the catheter insertion, I need to go 5 centimeters on top of that. For this, I'm going to actually insert the catheter further than 10, and then I'll pull back to 10 once I'm good there. So I'm going to go ahead and advance this just a little more. So maybe there's a false loss of resistance. Pull up more stable saline. Using the Bramage. Okay, that's definitely lost. There we go. So that's actually closer to 6. Get my catheter back. Make sure it still remains sterile, hasn't touched anything. Much better. Partially better. There we go. So we're going to go to 20. Now I'm going to pull out the 2E needle, making sure that the catheter stays in place. Holding on the catheter at the end. And like I said, I'm going to pull this back until we get to about 10 or 11. Actually 11 now, because it was a 6. Good. Okay, there's 11. And so now I'm going to go ahead and put this on before I take the drape off. Put it in, clamp it, make sure it's good. And I'm going to grab my test dose. So as I'm getting this ready and I'm about to inject, I'm just going to go over what the patient needs to tell me if they start feeling. They're hooked up to EKG and blood pressure, so before I do this, I'm also going to make sure that I have the blood pressure starting so I can get a baseline. I'm going to check their SpO2, which is also on, make sure that there's no drop or change in sound that could indicate early changes in heart rate or anything, as well as the EKG. Everything's turned up so that I can hear it before I see it if I need. And what I'm going to do is tell the patient to let me know if they feel like their heart's racing, if they have any ringing in their ears, any metallic taste, and then if they have an instant warmth down, since they're sitting up, it should be down kind of in the pelvis area or even down to their feet and toes. The instant warmth would indicate that there is a intrathecal injection, which means that I'm not in the epidural space and I have a spinal. And the metallic taste, ringing in the ears, dizziness, and increased heart rate would all indicate that I have an intravascular injection. Before I do that, I'm going to aspirate, check for any CSF or blood, and then go ahead and give my test dose. That'll take a couple minutes, or could potentially take up to a couple minutes, so we have our baseline blood pressure. We'll hit recycle. By the time that second blood pressure is done, we should have effects, which would indicate if we have a correct placement or not. So once that's done, we're going to go ahead and get rid of the drape. We're going to get this taped up in place. Which we don't have for the video purposes, but it would be a tegaderm. And then I'm going to tape up the back to make sure it's nice and secured, put it to the spot. And now that it's good, we can go ahead and give our loading dose. And like I said, that's 10 mLs with a mixture of fentanyl and bupivacaine. And we're only going to give about 2 mLs a minute just to help avoid any significant hypotension, especially in this patient. We'll just give that slowly over about 5 to 6 minutes. And then we won't need a continuous infusion, but we could get them into a post-operative continuous infusion if we needed to, and we'll just leave this, keep it ready to go, make sure it's labeled as an epidural because it is. Close this off, we're good there, tape it up. And then once the surgery starts, I'm going to go ahead and chart everything that I need for this. And for the first 15 minutes after, although we'll be in the OR, so I'll be doing it the whole surgery, but if this were outside of the OR, you'd want to check vital signs every 5 minutes for the first 15, just to make sure that there aren't any changes in heart rate, blood pressure, anything significant that you would need to watch. And so there's that. So now, not on this patient, I'm going to take this out, and we're going to go ahead and I'm just going to demonstrate how to do a spinal really quickly. So to do that, you would do the same prep. You'd make sure it's sterile. So we're going to fast forward through that. I'm going to get my supplies out. I'm going to prep the patient. I have my sterile gloves already on. Everything's prepped. I'll pull up my medications, which for a spinal are significantly less. In this instance, I'll pull up about 3 mLs total. It'll be 2 mLs of bupivacaine, 1 mL of fentanyl. The bupivacaine is 0.75, so 15 milligrams, and I have 50 mics of fent. I'm going to administer about 1.5 mLs of that combination. So it's significantly less. The local anesthetic is the same, so I'm going to have 3 mLs of 1% lidocaine ready just to anesthetize the skin. Get that ready. Okay, we're going to go through the same process of the drape. So the drape is on, and we're going to do the same thing for anatomical positioning and marking. So I'm going to check the iliac crest with a Toofer line, check for the interspinal space and processes. So we're good there. Once I have the landmark, which luckily is the same as before, do the same skin wheel. And going deeper. Now with the epidural, we had a 18 gauge Tui needle. With this one, we're going to have a 25 gauge Whitaker, so it's a pencil point. So it will need an introducer needle as well. I have my medication pulled up. Perfect, medication's good, vocal's good. So first, we're going to start with the introducer. Make sure we get there. Get it in. With the introducer, we're going to make sure we maintain midline, and we're only going to go through the initial skin. It's subcutaneous. We could go through the supraspinous as it is a sharp needle, but that's not necessarily the goal. Then we're going to get our spinal needle, and with this one, we're not going to have our glass syringe to do a loss of resistance. What we're going to do is we're going to kind of go, and especially with this smaller one, we should be able to fill the ligaments. So I can fill a pop through the interspinous ligament, supraspinous ligament, then interspinous ligament, and then ligamentum flavum is going to be the first big pop, which then I know the dura mater is next. Fill that pop. Good. So now we're in the subarachnoid space, and to just double check, once I fill that pop, or what I think it is, I'm going to pull this out, and I should get CSF. If I don't, I can go ahead, reapply, go a little deeper, and with the 25 I'll have to wait just a little longer because it is a small needle, but I'll see CSF coming out. That means I'm in the subarachnoid space, in the spinal space, which is good. So I can go ahead and grab my medication and hook it up, and I'm going to give this at about 0.2 mLs per second, so slower, because you don't want to cause profound hypotension or bradycardia or anything. And once again, this patient is being monitored with their blood pressure and heart rate as we're doing this. So once that's administered, we're going to pull everything out together. Good. And now, if we were to use the example of the patient we had before with the total knee, we're going to have them stay seated for just a little bit, and that gives us the saddle block. And then once that's done, we'd have them lay down. We can position them however we need so that we can have spread of the neuraxial anesthesia to give the best block for this patient. And once again, once this is done, you're going to check your vital signs every 3 to 5 minutes for the first 15 at least, and then you're going to go ahead and chart everything that you did. And that's my video.